Welcome back to the course on nutrition and planetary health, presented by the Physicians Association for Nutrition and PANCO. This course provides an evidence-based foundation for how dietary patterns influence both human health and planetary health, and how this knowledge can be applied in clinical practice to promote healthy and sustainable diets. Let's continue with the second module on the examples of healthy dietary patterns. Let's get started with Lesson 2.3, the DASH diet. Before you begin this lesson, please answer the following question. This ungraded question is designed to get you thinking. If you are unsure, take your best guess. Which dietary pattern was specifically designed and tested in controlled clinical trials to reduce blood pressure? A Mediterranean diet, B. DASH diet, C. Ketogenic diet, D. Low carbohydrate diet. The correct answer is B. DASH diet. Unlike many dietary patterns that emerged from cultural traditions and were later studied epidemiologically, the DASH diet was developed prospectively as a clinical intervention to reduce hypertension. In the early 1990s, hypertension remained highly prevalent despite pharmacologic advances. At that time, nutrition guidance often focused on individual nutrients, particularly sodium and saturated fat. In 1989, the U.S. National Research Council highlighted dietary modification as a central strategy for reducing the risk of chronic disease. However, the question remained whether an overall dietary pattern could meaningfully lower blood pressure independent of weight loss. The National Institutes of Health subsequently developed the dietary approaches to stop hypertension, or DASH. Eating pattern, National Institutes of Health, NIH, 2026. The approach emphasized whole foods rather than isolated nutrient restriction and was designed to be practical for long-term adoption. This shift from single nutrient advice to pattern-based intervention marked an important development in clinical nutrition. The DASH diet is defined by specific, quantifiable targets by the National Institutes of Health in the United States. This includes 4 to 5 servings per day of vegetables, 4 to 5 servings per day of fruits, 6 to 8 servings per day of grains, primarily whole grains, 2 to 3 servings per day of low-fat or fat-free dairy, up to 6 1-ounce servings per day of lean meat, poultry, or fish, 4 to 5 servings per week of nuts, seeds, and legumes, and limited sweets and sugar-sweetened beverages. Sodium intake is targeted at less than 2,300 milligrams per day, with a lower option of approximately 1,500 milligrams per day for individuals who would benefit from additional blood pressure reduction. This dietary pattern is intentionally rich in potassium, calcium, magnesium, and fiber. Estimated intakes in the original design approximate 4,700 milligrams potassium, 1,200 milligrams calcium, and 500 milligrams magnesium per day, levels substantially higher than those seen in many Western dietary patterns. This raises an important question. Is the benefit of DASH attributable primarily to sodium reduction, or to the combined effect of these nutrient shifts? Let's look at the evidence for blood pressure reduction. Controlled feeding studies show that the DASH diet can reduce blood pressure within approximately 2 weeks. Reported reductions in systolic blood pressure among individuals with hypertension have reached approximately 11 Hg, with diastolic reductions of approximately 6 Hg. These reductions are clinically meaningful. A reduction of 5 Hg in systolic blood pressure has been associated with approximately a 14% lower risk of stroke, a 9% lower risk of coronary heart disease, and a 7% lower risk of all-cause mortality. It is important to note that these reductions occurred independent of weight loss in controlled settings, suggesting that the dietary pattern may itself have direct effects on vascular health. Beyond short-term trials, observational evidence supports long-term benefits of the DASH diet. A 2020 systematic review and dose-response meta-analysis, including 13 prospective cohort studies and approximately 1.25 million participants, found that higher adherence to the DASH diet was associated with lower all-cause mortality. For every 5-point increase in DASH adherence score, all-cause mortality decreased by approximately 5%. These findings reinforce that the pattern matters beyond short-term changes in blood pressure. The effectiveness of the DASH diet likely reflects multiple interacting mechanisms rather than a single nutrient effect. This includes potassium, calcium, magnesium, and nitric oxide. Potassium promotes natriuresis and counteracts the pressor effects of sodium. Contemporary reviews describe potassium as an under-recognized determinant of cardiovascular risk. Increasing dietary potassium intake through fruits and vegetables shifts the sodium to potassium ratio in a direction associated with improved vascular outcomes. Low calcium intake has been linked mechanistically to increased activity of the renin-angiotensin-aldosterone system and higher vascular tone. The inclusion of low-fat dairy and calcium-rich plant foods may therefore help regulate blood pressure. Magnesium influences vascular smooth muscle relaxation and endothelial function. Earlier national dietary reviews recognize magnesium as relevant to blood pressure regulation. Leafy greens and nitrate-rich vegetables can increase nitric oxide availability, promoting vasodilation. Taken together, these mechanisms show that DASH is not simply a low-sodium diet, but a coordinated dietary pattern that improves mineral balance, supports vascular function, and reduces dietary components associated with hypertension. For patients with elevated blood pressure, dietary change rarely occurs in isolation. Exercise training has independently demonstrated blood pressure lowering effects. Combining regular physical activity with DASH may therefore produce an additive benefit. It is also relevant that higher consumption of red meat has been associated with increased risk of hypertension in prospective cohort studies. The DASH recommendation to limit red and processed meats aligns with this evidence. In clinical practice, the next question is often practical. How can this pattern be implemented across diverse populations? For individuals with lactose intolerance, which affects approximately 65% of the global population and up to 70 to 100% in some Asian and West African populations, Medline Plus. Similar nutrients can be obtained from fortified plant milks, soy products, legumes, nuts, and cruciferous vegetables. This flexibility is important for equitable dietary guidance. DASH emphasizes minimally processed foods. This structural feature may contribute additional benefits. A systematic review reported associations between higher ultra-processed food intake and increased risk of cardiovascular disease and mortality. A large UK biobank analysis also linked higher consumption of ultra-processed foods to increased risk of cancer and mortality. Thus, DASH may reduce risk not only through mineral optimization, but also by shifting dietary patterns away from high consumption of ultra-processed foods. Now, before you move to the next lesson, let's assess your learning through a quick question. Based on what you learned in this lesson, answer the following question. A patient with newly diagnosed stage 1 hypertension asks whether focusing only on salt reduction is sufficient. Based on the evidence, which response best reflects current understanding? A. Sodium reduction alone reproduces the full DASH effect. B. A coordinated, mineral-rich dietary pattern amplifies sodium reduction effects. C. Dairy intake must be eliminated for blood pressure control. D. Diet has minimal effect compared with medication. The correct answer is B. A coordinated, mineral-rich dietary pattern amplifies sodium reduction effects. The DASH framework suggests that while sodium reduction is important, the greatest and most consistent benefits arise when sodium moderation is combined with a mineral-rich, plant-forward dietary pattern. Before we wrap up this lesson, let's look at the key takeaways to recap what we learned. First, the DASH diet was developed as a clinical intervention to reduce blood pressure. Second, it specifies quantitative targets for fruits, vegetables, whole grains, dairy, and sodium. Third, reductions of approximately 11 Hg in systolic blood pressure have been observed in individuals with hypertension within weeks. Fourth, even modest reductions in blood pressure translate into meaningful reductions in cardiovascular risk. Fifth, higher adherence to the DASH pattern is associated with lower all-cause mortality in prospective cohort studies. 6. Benefits likely arise from the combined effects of potassium, calcium, and magnesium, improved sodium balance, and lower intake of red meat and ultra-processed foods. So far, This module has focused on how dietary patterns such as the Planetary Health Diet, Mediterranean Diet, and DASH diet affect human health. In the next lesson, we begin Module 3, shifting our focus to the environmental dimensions of diets and food systems. We will explore how food production and dietary choices affect planetary health, including climate change, land use, water systems, and biodiversity. We would value your feedback. Please scan the QR code on screen to share your thoughts on the course content and help us improve this learning resource. Thank you for watching this lesson. This is the course on nutrition and planetary health, developed and presented by the Physicians Association for Nutrition and PANCO. You can now move on to the next lesson.